Hey class, this is Dr. Turpin. I thought to help with time and so that we can have enough content to get through some of this stuff, I would go ahead and just tape the rest of our hygiene lecture, and then we can talk a little bit about it when we're doing the skin lecture for our next class on next Tuesday. I know we kind of got through ADLs and what those are, and we did go into detail about the nurse is still responsible for hygiene even though they're delegating that to the CNA. Just remember that there are a lot of factors that really affect what has been the typical self-care practices for hygiene for people. Psychosocial factors, personal preferences. You know, sometimes patients may have a certain routine and we try to go with what their routine is on when they want to bathe, if they want to be a daytime bath or a nighttime bath or every other day, or those kinds of things can be accommodated. Also, with products to use, we can use some of their products. You know, we looked at the CHG or the chlorhexidine wipes in class today, and so some of those products might be the policy of the hospital. Someone else might want to bring in some bathing products from home just because they smell good, or that's what they use for their skin being sensitive and things like that. So it's good to kind of, before you ever get into doing some hygiene with the patient, really talk to them about what they like to do, what's norms. If they don't understand about infection control practices like CHG, you know, that would be something that would be a good time to educate them more on that. And so you might want to do a combination. If the policy is to do, you know, the wipes, you know, then maybe you need to educate, maybe initially use some of the patient's products, or initially use some of our products and then finish up with some of their products. Either which way, whatever they feel comfortable with, so that you meet both goals. Cultural and religious practices are typically assessed for on admission. And so and some cultures and some religions have very specific beliefs about when bathing can be done, who does the bathing, and you know, there are also, it's important to remember that when you're doing a whole bed bath, or you know, helping somebody with a shower, this is very personal. This is when somebody is taking off all their clothes, and you are the caregiver, and you are seeing parts of their bodies that they may have never shown to a soul in their life. And so, you know, there has to be a level of trust and lack of fear, you know, so that they feel comfortable allowing somebody to, you know, physically clean them in areas when they're not able to do that. And it can be very scary for people. It can feel very like I'm out of control. I've lost my level of independence for a time period. So coaching them through that, and your demeanor and how you approach that, is very important to them psychologically, emotionally. So, you know, a lot is to be said when you're considering what their self-care practices are. You want to incorporate some of that, but always remember that this is a very personal thing for people. Other things that may really influence how well patients can do self-care of hygiene. Economic status can be a big problem. They may not have money to buy hygiene products. They may not have running water. We do work here in a rural area where some of that still is a consideration. So finding out again what is their norm is important. Developmental level, sometimes they, you know, if you have a child, you know, they may only allow their parent to help them with bathing. There might be times when, you know, I am a caregiver because I'm someone's daughter, and have an elderly parent that is now kind of cognitively impaired, but I don't feel comfortable as a daughter bathing my dad. So trying to really think about, all the things that might come up in terms of how this goes in advance, and asking questions and assessing this condition of how they normally do things gives you a better idea of how to educate people, find out their knowledge level in terms of what do they know about hygiene and how it might be good for them from an infection control standpoint. They may have limited knowledge, and it's a good time to really assess both knowledge and capability and the typical self-care, and then try to work on a plan for how you can kind of provide that or assist them in caring for themselves in the healthcare facility. There's lots of physical factors that really influence self-care. Pain may limit people from even wanting to do hygiene practices. A limited mobility. They may can bathe some parts of their body but not all. They may be in the bed and not have a lot of assistance to be able to clean themselves. Sensory deficits. Sometimes they may just not get up and do things from a safety concern. Can't feel my feet, so I don't really feel comfortable standing and getting in and out of a shower, so they may not get cleaned real good. Other physical factors, cognitive impairments. Sometimes patients forget when they had taken a bath last, or don't even know when it's time, or maybe forget actually how to really go from putting tooth on a toothpaste, and how do they do the steps anymore. They may have lost that cognitive ability. Emotional disturbances. Patients that are very depressed, will be very withdrawn, and often they'll go days without bathing. And and sometimes their reality is so different they don't even recognize that there is a hygiene need. So, which factor would be most likely to influence the patient's influence the hygiene practices of a homeless client? Well, obviously, several of those things are all, as we've spoken before, good answers, but actually see the client's living environment is most likely going to be the biggest influence for a homeless client. So again, remember those test questions are going to be like that. Some of them are really good, but doesn't mean it's the best answer. In hospitals, you're going to see all different kinds of hygiene policies on when do we do stuff. I think your book really talks about, kind of dividing it up into early morning care, AM care, PM care, and then HS or bedtime care. And these are just some examples, but it's important to go into the facilities and really find out what is the routine here. Sometimes they may have, some of the baths are during the day, some of the baths, because of patient preference, have been scheduled for the PM shift. And so, as a general rule, getting people up early in the morning and washing their face and hands and getting them ready for breakfast should be sort of a norm. But after that, it kind of becomes what is the patient's preference. So, even though they've given you these guidelines here for kind of some typicals, always know that you need to kind of find out what the facility norm is. So what would you assess prior to delegating hygiene care to a nursing assistant? Well, first off, I'm going to want to know, how long has this CNA been a CNA? Are they competent to do bathing? Have they been checked off on all that? Have they had a good track record of doing bathing? Have I seen that with them in the past, that kind of care? The best thing to do is kind of meet with the CNA in the beginning of the shift and kind of get an idea of who do you know needs a bath during our shift, how much assistance are they going to need, so that it's very much a team approach to how to provide hygiene care. hygiene care gives you a great opportunity to look at the skin and do a really good assessment. So you're going to want to be in there at some point when hygiene is taking place, if at all possible, so that you can kind of do that while you're helping with the other process. So you really kind of want to know also how heavy is that person's workload today. You know, they may have a very large assignment and you have a small assignment. You might need to pick a patient and help them and work with the patients. And then organizing things on maybe somebody doesn't need a bath because they're going home today, or they're going to surgery and they already had a bath, you know, pre-operative bath already, early morning already. Those are things that are good to make sure that everybody's on the same page with. And what would you do if the nursing assistant documents that the patient refused a bath? Well, for the record, typically there are some facilities that don't even want CNAs to document that until they have come and spoke with the nurse about it. It gives the nurse an opportunity to go in, coach the patient, encourage the patient. If the patient is demented and not wanting to bathe, maybe it takes two people to kind of encourage them to let us go ahead and get this started. So, you know, typically I want to let my CNAs know that, you know, just don't document that. Come find me before you put that in the record, because we really need to kind of work as a team to see that people get the hygiene care that they need, and not document that unless we both really agree that we've done everything we can before putting that in the record. Like I said, you're going to do a great assessment of the integumentary system while you're doing this, and I'll deal with this a little bit more in the skin and wound assessment lecture. This is just a breakdown of how you might see some terms for what a bath is called. An assist bath might be where you just bathe the areas that are hard to reach and you let the patient do as much as they can for the areas they can reach. Partial bath might be they've already had a bath but they've had an incontinence episode, so you went in and you provided just care or cleaning to the perineum. And then bed baths can be considered complete, partial, or a help bath where you kind of help them with things, or only did part because they wouldn't let you do but part, or if they had complete. Other methods of bathing, you know, bathing can be set up like where you're doing it with towels, the prepackaged things we looked at today. They can be assisted in the shower. Showers are tricky with patients, and so patients, you really need to stay with them from a safety standpoint at all times if they're in the shower or as a close standby. And then some facilities will actually have tub baths or whirlpool baths that they use to kind of clean the patient. They may not do that every day, but they may have a period of time where they do that periodically throughout their stay. These are just some more showing you some of the items that you use for oral care. These are kind of the reasons that we want to do oral care. But again, the biggest issue is really cutting down on that biofilm, which is the big precursor to pneumonia. Again, you use that time also to assess in the oral cavity. These are the things that you're kind of looking for. Do they have cavities? Do they have missing teeth? Do they have gingivitis or an inflammation of the gums? In the other parts of the mouth, sometimes they may have lesions or sores in their mouth, or, you know, some types of inflammation that you would want to document and let the doctor know about. And then really trying to control that biofilm, again, is the biggest key issue that we're after there. When providing oral care for the unconscious patient, the nurse should, and this one kind of talks about what we talked about in class, like making sure that you have them in a position that is the best to prevent aspiration of some of the fluids that you would have in their mouth during that time. In terms of care of the feet, we're going to look at some feet when we talk about skin care and how diabetics are done. But a lot of diabetics, we do not clip nails. We have to do very specific care to the feet to not just clean them but dry them so that they don't have opportunities for infections. And then for hair care, there's different things that we do in terms of regular bathing and hair caps. These are just a slide that also mentions make sure you're cleaning the eyes and the ears good.